Good evening, everyone. So today I'm going to discuss about the Amphigen pattern of glomerular injury. Uh, as we know that there was a time that when Amphigen used to be considered as membranoproliferative glomerular nephritis, and whenever you get a diagnosis of Amphigen, you used to feel that we are dealing with a membranoproliferative glomerular nephritis only. But now, majority of the glomerular diseases can show Amphigen pattern. So now Amphigen as such, we hardly label Amphigen as the diagnostic line. We always say in some glomerular diseases, we label it as a Amphigen pattern. So membranoproliferative pattern of glomerular injury rather than a MPGN. Okay, so that is very important that whenever a pathologist gives a diagnosis that it is a membranoproliferative pattern of glomerular injury, you should not jump to a conclusion that it is immune complex mediated Amphigen or it is something related to uh, infectious pathology or something related to autoimmune disease, that kind of a thing. So you should remember that even IgA nephropathy can have a Amphigen pattern. Lupus nephritis can have Amphigen pattern. Diabetic nephropathy can have Amphigen pattern. Chronic thrombotic microangiopathy can have Amphigen pattern. And there are a lot of other diseases also which can show Amphigen pattern. So I'm going to show you some diseases which show classically this kind of Amphigen pattern of glomerular injury. And what I want to highlight is that whenever you get this diagnosis, the Amphigen pattern, don't jump to this conclusion that it is membranoproliferative glomerular nephritis. Okay, so first I'll show you how Amphigen looks like. So when we say that this is Amphigen, so when you look at the globulus, you see that these are the glomerular capillary loops. You can see these are the glomerular capillary loops which are empty, and there are certain glomerular capillary loops which are showing cells. And these cells are, as you can see, these are neutrophils. These are segmented cells. They are bilobed cells, and at places they have 3 lobes. So these are neutrophils which are seen within the glomerular capillary loops. In addition to that, there are some capillaries which are showing clearing of the membrane. So that means there is a duplication. So you are finding duplication, you are finding endocapillary proliferation with presence of either it could be neutrophils or lymphocytes. Okay. So presence of duplication, presence of endocapillary proliferation, and mesangial expansion. So mesangial expansion is best highlighted by PS stain. This is the HND stain, but even this area, this is a mesangium, and you can see 1, 2, 3, and 4 nuclei here. So that means it is a membranoproliferative, or sometimes you also label it as a mesangiocapillary pattern. So in this, morphologically also it looks like a glomerulonephritis because there are inflammatory cells which are there in the capillary loops. So whenever we say that there is an Amphigen pattern, so that means there will be some mesangial expansion, there will be thickening of the capillary wall, there could be duplication of the capillary wall, there could be endocapillary proliferation, there could be crescents also. So there are some Amphigens which are more chronic. You will not find any activity in form of endocapillary proliferation or crescents, but there are certain type of Amphigen which when they become chronic, when they are acute, they will show all these active changes in form of endocapillary proliferation as well as presence of crescents. So this is another Amphigen pattern in which you can see this is a PS stain. You can see a Bowman's capsule here, and there is a crescent, and underneath the glomerular tuft is showing significant thickening. So when I say there is significant thickening of the glomerular capillary wall, just compare this glomerular capillary wall with the tubular basement membrane. It should be non-atrophic tubules. So if you compare it with the tubular basement membrane, this appears thicker than this tubular basement membrane. So that means the glomerular capillary wall is thickened. In addition to that, you can see some cells. These are lymphocytes within the glomerular capillary loop. So that means this is an Amphigen which is showing a crescent as well as endocapillary proliferation with presence of lymphocytes. Now, with this kind of a morphology, if you see dominantly full house, if you see full house immunofluorescence pattern with IgG, IgA, IgM, that means all the immunoglobulins as well as all the complements, that means C3 and C1q, and kappa lambda shows no restriction, then it is pretty consistent with the diffuse proliferative lupus nephritis. Okay. Now this is a Mason's trichome stain, and Mason's trichome stain shows that there are these kind of reddish color deposits. So when we were not doing immunofluorescence, so there was time when we pathologists used to do Mason's trichome or empty stain, which was not only for commenting on interstitial fibrosis, but also it was a very useful stain to comment upon whether there are some immune complexes. So immune complexes used to appear as red color deposits. So what you can see here, so this is a glomerular capillary loop. Inside there is a red color deposit. That means it is a hyaline thrombi kind of structure, what you are seeing. Okay. So presence of these kind of hyaline thrombi in the glomerular capillary loops, as well as there are some capillary wall. You can compare it. This capillary wall appear thin and this capillary wall appear thick because of this kind of massive deposit. So these are also called as wire loop lesions. So wire loop lesions, hyaline thrombi, when you see, it is classically seen in lupus nephritis. However, the similar finding can also be seen in cryoglobulinemia. Okay. So I just want to highlight that there are certain glomerular nephritis which has got a mixed pattern. So when I say mixed pattern, that means this glomerular nephritis can have mesangial expansion also, mesangial hypercellularity also. They can have membrane thickening, duplication, endocapillary proliferation. So whenever you see a mixed pattern of glomerular injury, there could be segmental stenosis. So a mixture of patterns, that means segmental stenosis, membrane thickening, Amphigen pattern. And whenever you find a mixture of patterns, there are only two types of glomerular nephritis which can show a mixed patterns of glomerular injury. First is IgA nephropathy and second is lupus nephritis. And both these pathologies, they have got classification system. So any renal pathology disease disorder which has got a classification system, that can show a variable morphology. So for example, like in this case, you can see this glomerulus. So this is a panel of photomicrographs, and this case is of IgA nephropathy. So what you can see here is that this glomerulus is showing these are the nuclei which are there in the mesangium. So that means there is mesangial hypercellularity. There are 4 nuclei here. Okay. So there is mesangial hypercellularity. In addition to that, this is a Mason's trichome stain which shows this kind of a red color thing. This is not deposit, this is necrosis. So there is one glomerulus which is showing mesangial hypercellularity. There is one glomerulus which is showing fibrinoid necrosis. Okay, that means necrotizing lesion. Okay, the other glomerulus, this glomerulus, what it is showing here, it is showing a segmental sclerosis. You can see here this segment is sclerosed and it is adherent to this Bowman's capsule. So there is a segmental sclerosis. In addition to that, this area is also showing mesangial hypercellularity. There is one glomerulus which is showing presence of this kind of a endocapillary proliferation. So this is like a mixed pattern. One glomerulus with mesangial hypercellularity, one glomerulus with fibrinoid necrosis, one glomerulus with segmental sclerosis, and one glomerulus with endocapillary proliferation. So this kind of a pattern you see in IgA nephropathy as well as in lupus nephritis. So when you do immunofluorescence, you see that IgG is negative, IgA is 3+, IgM is negative, C3 is 1+, kappa is 1+, and lambda is 3+. And this is very classical example of IgA nephropathy. And you have to remember that IgA nephropathy will show majority of the times more kappa staining as compared to more lambda staining as compared to kappa. So that doesn't mean that we are dealing with some kind of a monoclonal pathology. It is a very common phenomena which you see in primary IgA nephropathy, where lambda staining will be more as compared to kappa. This is another photomicrograph panel which shows that this glomerulus is showing a thickening of the glomerular capillary wall. These are the endocapillary spaces which are empty. That means there is no cellularity here. This area is showing some kind of a mesangial expansion and hypercellularity, and the capillary loop is the patency of the capillary lumen is gone. This is a Mason trichome stain which shows these kind of fishnophilic or reddish color deposits which are there. That means there are some wire loop lesions. This glomerulus is showing the cellular crescent. This glomerulus is showing the necrotizing lesion. So this glomerulus as well as this glomerulus as well as this glomerulus as well as this glomerulus is showing variable morphology. So necrotizing lesion, wire loop lesions, mesangial hypercellularity, crescents. So If you find full house immunofluorescence pattern, then the diagnosis is diffuse proliferative lupus nephritis. So it is a combination of light microscopy and immunofluorescence by which we are able to diagnose entities. So I'll come to one case presentation. 32-year male, increasing pedal edema for 1 month, fever for 1 month, no joint pains, rash. On admission, patient was hypertensive, blood pressure was 170 by 110, and hematology profile shows hemoglobin of hemoglobin of 8 grams, TLC was 5,600, and the urine routine microscopy showed 3 plus proteins, RBCs was 12 to 15, 24-hour urine protein is 15 grams, and serum creatinine was 3.7 milligram. So proteinuria with deranged renal function. The clinical diagnosis was RPRF, query Amphigen, query SL. So this is the morphology. You can see there is lobular accentuation. So when we say lobular accentuation, that means the globular tuft seems to be separated out into different segments. So this is one glomulus. It seems that there is one segment here. There is a space in between. There is one segment here. There is a space in between. There is one segment here. There is a space in between. This one segment is there. Then there is space. And this one segment. So there is a lobular accentuation. In addition to that, and this is a PSTN, which shows there is lobular accentuation. The capillary loops are full of cells. That means there is endocapillary proliferation. In addition to that, there is one glomulus which is showing a cellular crescent here. And this is a high power magnification which shows that there are some wire loop like lesions or hyaline thrombi which are there. Okay, there is endocapillary proliferation which is there. And the capillary lumen and the capillary wall also, there is a thin membrane like this and there is a thick membrane like this. Or you can say this membrane and this membrane. So there is a non-uniform thickening of the membrane with lobular accentuation. So this lobular accentuation can be highlighted here also. You can see one segment here of a glomulus and there is a space, and there is one segment here and there is a space in between. Okay. And this is a PS stain which shows that there is a cellular crescent which is there, and there is a hyaline thrombi kind of structure, and this hyaline thrombi is better highlighted. So morphologically, there is mesenteric hypercellularity, there is hyaline thrombi, there is crescent. Morphologically, the first is, and this is a Mason's trichome stain which shows that there are dense eosinophilic deposits which are there. That means reddish color deposit. So surely we are dealing with the immune complex mediated disease. But what immune complex mediated disease? If, for example, in this case, there is a full house immunofluorescence pattern, then it becomes a class 4 lupus nephritis. But in this case, the immunofluorescence show IgG and C3 only. There was no C1q. Okay, so there was no C1q. So based on this, you will label this as an immune complex mediated Amphigen because there is IgG as well as C3. There is no C1q. Morphologically, it looks like an immune complex mediated Amphigen. Okay. Since there is no C1q, there is no full house immunofluorescence pattern, the possibility of lupus nephritis is out. The other thing is kappa lambda was not showing any restriction. So the possibility of Amphigen with this proteinuria is also gone. So what we are seeing here is there is an Amphigen which has got hyaline thrombi or wire loop like lesions. And whenever you see hyaline thrombi like this or wire loops or these are the similar things. Okay. So you should always have two differentials in your mind. First is lupus and the second is cryoglobulinemia. So this patient should be investigated on lines of cryoglobulemic glomerulonephritis because there are these kind of eosinophilic or reddish color hyaline thrombi which are there. So the light microscopy and immunofluorescence, we are able to give a final diagnosis of this. Electron microscopy will be helpful in demonstration of whether what is the location of these deposits and whether they are showing any substructure. But on light microscopy immunofluorescence, you will be able to categorize majority of these patients. I'll come to another case. 67-year female with hypertension, nephrotic proteinuria, deranged renal function, inactive urinary sediment is present. So diagnosis was MGM. If we look at this, so this also, this glomulus has got this cellularity which is there in the mesenteric. There are these capillary loops with neutrophils. Some of the capillary loops are empty. They are showing RBCs like this. Some of the capillary loops are showing cells like these, lymphocytes, neutrophils. There is mesenteric hypercellularity. And if you compare the membrane also, so there is a membrane like this and there is a thick membrane like this which appears duplicate. So non-uniform thickening and duplication of the membrane, and you can see it's a similar duplication here. Mesenteric hypercellularity, endocapillary proliferation. So this is classical like a Amphigen pattern. Now, when we did immunofluorescence, there was IgG which was there, there was C3 which was there. So both IgG, C3, that means it is a immune complex mediated disease. We did IgG subclasses. So IgG subclasses show dominantly, I should not say dominantly, only IgG3 subclass. So this is very important. When you see only one IgG subclass, the other thing you should look carefully is kappa lambda. So here there was kappa restriction. There was no lambda, there was only kappa. So it is an amphigen with dysproteinemia, or in other words, this is IgG3 kappa amphigen or amphigen with dysproteinemia, or they are all now also labeled as proliferative GN with monoclonal IgG deposits. So this is so I've shown you a case of amphigen with Woodhouse immunofluorescence pattern, which is like lupus. Then there is immune complex mediated amphigen with hyaline thrombi and only IgG3 and no kappa lambda restriction, no light chain restriction. That is immune complex mediated amphigen, possibly cryoglobinemic. And the third is amphigen with dysproteinemia. So these are the three broad headings in which you divide amphigen. So when I'm talking about amphigen, I'm not talking about membranoproliferative pattern of glomerular injury. So membranoproliferative glomerular nephritis, now we have to label whether it is an immune complex mediated amphigen, and this immune complex mediated amphigen could be related to infections, hepatitis B, C, or any other infections, viral infections, or this immune complex mediated amphigen could be related to autoimmune diseases. If both these etiologies are, if both these histopathologies are not there, then we need to look very carefully in the kappa lambda staining, whether there is any light chain restriction, because there could be then the third broad category of amphigen with dysproteinemia. And the electron microscopy, when it was done in this case, so I will just run through this slide because these were the deposits and they were showing a lot of fibrillary architecture. So there was some substructure. So whenever you find a substructure within the deposit, so normally the deposits will appear like this, electron dense deposition in ultrastructure examination or in electron microscopy. But when you find substructure within these electron dense deposits, you should suspect possibility of dysproteinemia. Similar substructure can also be seen in lupus nephritis, but as I've shown you, in this case, there was no C1q, there was no full house immunofluorescence pattern, so lupus nephritis is out. It's just a high magnification to highlight that there was a fibrillary kind of structure which was there in these deposits. So they were like, I won't say fibrillary, but they were like microtubules kind of things which are parallelly aligned. So this comes under MGRS associated lesions, as you can see here, proliferative GN with monoclonal C3 deposits, PG and MID, or in other words, MPGN with dysproteinemia. So they come under MGRS associated lesions. So then now majority of these cases of amphigen which I've shown you, IgG was there. Okay. Now you see a case, a 60-year male with nephrotic syndrome and active urinary sediment. The capillary loops are significantly thickened, and it is showing again. It is showing an amphigen kind of pattern. Okay. I just run through this amphigen pattern. When you look at immunofluorescence was showing only C3 deposits. IgG, IgA, IgM is negative. Only C3 deposit is there, and C1q is negative. So practically, whenever you find there is an amphigen pattern on light microscopy, and immunofluorescence show only C3 deposits, then your diagnosis should be C3 globulopathy. Okay. Since there are no immunoglobulins, so kappa lambda will not come. So kappa lambda will be negative because light chains always accompany heavy chains, heavy immunoglobulins. So if the immunoglobulins are not there, light chains will not be there. So in C3 globulopathy, there will be no kappa lambda, which will be seen in the globulin. Okay. So I did paraffin immunofluorescence also in this case. Can somebody tell me what was the reason why I did paraffin immunofluorescence in this case? Can someone answer?
Do we want to unmask because more than 50 years with C3GN?
Absolutely correct. Because I have given you the history. This is a 60-year. That is why I gave this history. This is a 60-year male with nephrotic syndrome and active urinary sediment. So you have to remember C3 globulopathy is a diagnosis of children and young adults. The moment you diagnose anyone as and if you get a diagnosis of C3 globulopathy in an elderly patient, you need to rule out possibility of any masked IgG deposits. And even if there is no masking, for example, in this case, paraffin immunofluorescence was done and there was no masking of deposits, IgG, IgM was still negative, and the only thing was complement was there. So that means even in elderly patients, if there is no masking, unmasking, and you get C3 globulopathy, C3 globulopathy in elderly patients, these patients should be investigated for underlying lymphoproliferative disorders or underlying plasma cell dyscrasias. Because what happens is the monoclonal serum, monoclonal immunoglobulin, which is there in the serum, which is not detected by routine immunofluorescence as well as electrophoresis, and even the serum free light chains will be fine. That causes complement activation, and that because of that complement activation, there is glomerulonephritis, and this glomerulonephritis show only C3 deposit. So that is a pathogenesis behind C3 glomerulopathy in elderly patient who are associated with MGRS. So MGRS also includes C3 globulopathy in elderly, provided you are able to demonstrate a monoclonal serum, band in the serum, or you are able to demonstrate that this C3 globulopathy is not C3 globulopathy after you did paraffin immunofluorescence. Okay, so then it becomes an Amphigen with masked IgG deposit. But this case, there was no masking of IgG deposits. Even in paraffin immunofluorescence, there was only C3 which was deposited. So you have to remember this important point that C3 globulopathy is not a disease of elderly population. So this is C3 globulopathy, and we did electron microscopy. Electron microscopy, you can see this is a globulobasal membrane. This is endothelial cell which is swollen. You can see some light pale color deposits. So I've shown you the previous image where the deposits are very dark color, electron dense. But in C3 globulopathy, the deposits are pale, waxy kind of deposits, which are there. You can see these kind of pale deposits. They are not that electron dense. Okay. So you can see this is a globulobasal membrane, and if I show that there are some kind of darker areas here in the subendothelial space, and these darker areas are not that dark, and you can also see some dark stuff here. Okay, so these deposits are not that electron dense, and in some areas you are going to see remodeling also. You can see a pale kind of appearance. That means the new GPM tries to form. What happens in Amphigen, the pathogenesis is there is endothelial injury and repeated endothelial injury that leads to remodeling. That is why remodeling, because of the remodeling, what you see of the GPM in electron microscopy, that can be appreciated as a duplication of the glomerular capillary wall under light microscope. Okay. Okay. So now the thing is, if there is C3 glomerulopathy, you need to say whether it is C3 glomerulonephritis or dense deposit disease. So you can't diagnose C3 glomerulonephritis or dense deposit disease based only on light microscopy. So if you find intramembranous electron dense deposit like this, interrupted electron dense deposit, sometimes they are interrupted, but sometimes they are not. They are continuous also. So these kind of electron dense deposits, intramembranous, if you see, that is classical of a dense deposit disease. And if you find pale kind of deposits, like you can see this GPM here, these are the podocyte food processes and podocyte cytoplasmic projections. And here you can find these deposits. These are pale. These are not as electron dense, what you can see here. So this is a C3GN, and this is dense intramembranous osmophilic deposit. This is dense deposit disease or triple D disease. So this case was consistent with C3 glomerulonephritis. So MPGN pattern you can also see in certain deposition disease. So before I come to the deposition disease, I just want to show you. So what do you think this is? What this image shows? Can somebody answer this? This is a glomulus.
Nodular glomerulonephritis.
Absolutely. Yes, this is a KW lesion, nodular glomerulus. So if you look at this glomulus carefully, what you can see here is there is a membrane like this, okay? And then there is a membrane like this, a thick membrane like this, okay? So there is an, again, just compare this membrane with this membrane, okay? So there is a non-uniform thickness of the glomerular capillary wall. Along with that, there is mesangial expansion. In some areas, the mesangial expansion is so significant it is forming nodular lesion. So practically, this is also Amphigen pattern with occasional mesangial nodule formation or occasional mesangial nodular glomerulosclerosis type of region. So when you see this kind of a morphology, the three differential diagnoses which you consider is first is diabetes, second is diabetes, and third is also diabetes. You have to remember that after you exclude diabetes, then only you jump to other conclusions like this could be light chain deposition disease and other stuff. Okay. So this is a silver stain, and silver stain shows that this mesangium is dark in color. You have to remember that had it been deposition of some other material in the mesangium, it should be PS and silver negative. Okay. But here it is silver positive. When I say silver positive, that means it is black in color. Normal mesangium is also black in color. So here also you are seeing blackish appearance of the mesangium. That suggests that it is the normal mesangium which is getting expanded, and there is no exogenous material which is getting deposited in the mesangium. And albumin stain shows that there is some albumin staining, and whenever you see albumin staining with nodular glomerulosclerosis lesion, your first diagnosis should be diabetic nephropathy. So albumin staining will be seen along the tubular basement membrane also, as you can see here. And even IgG will show some kind of a linear accentuation or minimal linear staining along the tubular basement membrane. Can you tell me any other conditions where you find linear staining of IgG?
Anti-GBM.
Absolutely, anti-GBM. So in anti-GBM also, but in anti-GBM you should find presents, you should not find these kind of nodules. Okay, so that is why it is not anti-GBM disease. So you have to remember that this is diabetic nephropathy, and this kind of IgG staining. When we see in diabetic, we never say linear staining. We always say linear accentuation. And you have to remember that albumin staining will be seen commonly in diabetic nephropathy only, but linear accentuation or minimal linear accentuation of the glomerular capillary wall as well as the tubular basement membrane can be seen in diabetic patients as well as in elderly patients also. Okay. So it is diabetic nephropathy. Sometimes these nodules, just compare this nodule on the left side and just compare these nodules on the right side. So if you see, I said just compare this nodule on the left side because there are only two such nodules, and just see the nodule which are there on the right side. So there is one nodule like this, one nodule like this, one nodule like this. So when you find multiple nodules in a globulus, and these nodules are of more or less similar size, look at this nodule, this size, this nodule looks very small, so variable size nodules. And when you find all nodules of same size and these nodules are more in number in a single globulus, you should morphologically suspect light chain deposition disease. And when you suspect light chain deposition disease on morphology, immunofluorescence is going to help you, or immunofluorescence is going to confirm whatever you have seen under light microscope. And immunofluorescence shows only kappa staining along the tubular basement membrane. The cast are staining 3+, even lambda is staining 3+ in the cast. But look at the tubular basement membrane. There is no staining in the tubular basement membrane. So it is light chain deposition disease. Okay. Even heavy chain deposition disease can show this kind of a nodular glomerulosclerosis lesion or an Amphigen. So even this also, this is like a lobular accentuation of the glomerulus, an Amphigen pattern. Only thing is Amphigen pattern, but nodular glomerulosclerosis lesion. Okay. And then you see this kind of IgG, which is there. There is kappa, which is negative. There is lambda, which is negative. So only IgG is there. So when you find only heavy chain and you find this kind of nodular lesion, so it becomes heavy chain deposition disease. On the other hand, if you find this kind of nodule and you find IgG and there is kappa and there is no lambda, then it is heavy light chain deposition disease. Okay. And only light chain deposition disease you say only if there is no immunoglobulin. That means no IgG, no IgA, no IgM, only kappa and lambda is negative, or only lambda and kappa is negative. Majority of the times in light chain deposition disease, it is kappa restricted. Okay, so it is a combination. Light chain deposition disease, heavy chain deposition disease, or heavy light chain deposition disease. So I'll come to this case. 62 female. So we are talking about deposition disease only. 62 female, no previous comorbidities, had history of road traffic accident 2 months back, AKI 2 months back, recovered to normal, presented with acute kidney injury 15 days back with nephrotic syndrome. So the suspicion was whether contrast induced or MGN or MCD. This is just a normal glomerulus for comparison. So what do you think this glomerulus has? Anyone can answer? What do you think the right side image glomerulus is showing? This is a PS stain. So this is a normal glomerulus on the left side where you can see these capillary loops. There is some mesenterium. And on the right side, what you can see here is, anyone?
Is it messenger lysis?
Okay, a very good morphological differential, I would say, that mesenteriolysis you are thinking, because there is the mesenterium is pale, okay, but you have to remember when the mesenterium is pale and it is PS negative or pale or PS weakly positive, you should also think of amyloid, okay. So, and whenever there is mesenteriolysis, so what happens is, since you are saying lysis of the mesenterium, so mesenterium is like a supporting media, okay, it holds all the capillaries together. So whenever there will be mesenteriolysis, the capillaries, they will not have any support and they become very dilated and congested. So that is not happening in this case. But yes, mesenteriolysis will be a good morphological differential here. But this is amyloid. This is a PS negative material which is false. And look at the capillary loops. They are just fine. They are not showing any RBCs. They are not showing any congestion. They are not markedly dilated. So what you are seeing is PS negative material which is deposited in the mesenterium. And just for comparison, I told you that normal mesenterium is silver positive. Look at this mesenterium. This, and silver positive means black color. So look at this mesenterium. So these capillary loops are black in color, but this mesenterium is silver negative. So whenever you find silver negative and PAS negative material in the mesenterium in the glomerulus, think of amyloidosis. And the further help will be the similar deposition can be seen around the blood vessels. But sometimes in cases of primary amyloid, early cases of primary amyloid, you will not find deposition in the blood vessels. You will find deposition only in the glomerular compartment. And this is a congruent stain which shows congophilia, because when I say congophilia, that means congruent stain will produce an orange color wherever the deposition is there. So there is orangophilia of the amyloid which is getting deposited on the vessels here. This is a glomerulus where also you can see this kind of congophilic material. The first step is you should find PS and silver negative material. That gives a suspicion that this is amyloid. You do congruent stain, it shows congophilia. And when there is congophilia, then you see under a polarized microscope and it shows apocrine bright fringes. So then the diagnosis is amyloidosis. But now you need to categorize this amyloid, whether it is primary or secondary. So why this is under Amphigen pattern? So just look at this glomerulus. So that is why I brought this under a differential of Amphigen pattern of glomerular injury. Just compare this membrane and just compare this membrane with this membrane, or maybe this membrane, or this membrane, or this membrane. So there is a non-uniform thickening. There is a mesangial expansion. So there is some kind of a Amphigen pattern which is there. Serum amyloid associated protein was done, which was negative. Kappa lambda. What do you think kappa lambda is showing? This is a glomerulus, this is a vessel. Anyone? Do you think there is any restriction here in kappa lambda?
It's lambda restricted.
Yes, absolutely lambda restricted. Lambda is like 3+ staining and kappa is negative. So it is primary amyloidosis, lambda restricted. Okay, now these are last few slides. So just see this glomerulus. And this patient is a 40-year male and previous biopsy reported as diabetic nephropathy. This patient has a long history of diabetes over the last maybe 10 years, 10, 15 years. And this morphologically, it was looking like actually nothing against diabetes. There was these glomeruli are large. They are showing one glomerulus is globally sclerosed. And it seemed that there is some kind of maybe a crescent. That is unusual for diabetes to have a crescent, but sometimes what happens is a globally sclerosed glomerulus, the overlying podocytes and the parietal epithelial cells, they start showing reactive proliferation, which will appear as a pseudo crescent. Okay, so actually not a true crescent, but a pseudo crescent. So in this case, I won't be able to definitely say whether there is a pseudo crescent or a true crescent, but it looks like a pseudo crescent rather than a true crescent. Reason being, the Bowman's capsule is absolutely intact. Normally, whenever there is a crescent, there will be some rupture in the Bowman's capsule. There will be some reactionary changes in the Bowman's capsule which are not occurring. Now we will concentrate on this glomerulus. So this glomerulus is showing again a Amphigen pattern. So why Amphigen pattern? Because the mesenchyme is expanded. Okay, there is a glomerular capillary wall which appear thinned out, but some areas like this area, this capillary wall appear thickened. Okay, there is thin and thick membrane. There is mesangial expansion. I would say there is a lobular accentuation also. You can see one segment here. There is a separation here, one segment here. Okay, so there is some kind of a lobular accentuation. There's a high magnification of the same, just to highlight that there is a thin membrane like this and there is a thick membrane like this. So whatever is there in the mesenchyme, the important thing is this material, whatever is there, it is PS positive. It is not PS negative. So look at this PS. Normally, the PS shows this kind of a magenta color in the Bowman's capsule. Okay, and mesenchyme is also PS positive. So this material is not like PS negative material, what I've shown you in the previous case of amyloid, where the material was PS negative. So this is a PS positive material which is positive. And I've shown you PS positive mesenchyme in diabetic nephropathy. Okay. And even in light chain deposition disease, it will be PS positive. In a heavy chain deposition disease, it will be PS positive. But here I'm not seeing any nodular lesion. So I don't want to bring in a differential of light chain or heavy chain deposition disease. But there seems to be mesenchyme which seems to be expanded. And this mesenchyme is also going, this material, whatever is there, this is PS positive material, is also getting, is also going into the capillary wall. So you can see these capillary wall also, similar material is getting deposited there, but it is PS positive. There's a high magnification just to highlight that this glomerular capillary wall is fine, this capillary loops are empty, that means there is no endocapillary proliferation, but this area is showing this mesenchyme which is there, this is getting deposited along the capillary wall also. Okay, so this is not so easy case. When we did IgG was showing some kind of a staining which was there in the mesenchyme. Okay, and this patient is diabetic. I've told you that there will be some kind of a linear accentuation. So you can see some kind of a linear IgG accentuation here. It is not like a anti-GPM, but there is some linear accentuation. Okay, anti-GPM will show a 3+ kind of staining. Okay, but it will not show staining in the mesangial area. So what you can see here is there is some kind of staining. So this staining was not like granular staining, what you see in immune complex mediated disease. It was a very smudgy kind of staining. We did DNA JP9 stain, and DNA JP9 shows brown color staining in the areas of deposition. Okay. So what do you think is the diagnosis? You know DNA JP9 is a marker for which pathology?
Fibrillary
Yeah.
glomerulonephritis.
Absolutely. So this is, so we are dealing with fibrillary glomerulonephritis, which was initially reported from 2 centers as diabetic nephropathy. And I must say that we have started picking up fibrillary glomerulonephritis by doing immunofluorescence. So what we did the slide which I'm showing you, this is a paraffin immunofluorescence we did. So by paraffin immunofluorescence, whenever you find smudgy IgG staining in the glomerulus, okay, your first suspicion should be whether I'm dealing with fibrillary glomerulonephritis, provided it has got a Amphigen pattern and mesenchyme which is expanded. Okay, then you do the stain, and obviously you have to do electron microscopy also. So I think this must be last 1 or 2 slides. So this case, a known case of breast carcinoma post chemotherapy, and I must tell you, looking at the morphology, my first diagnosis was, because when I compare this membrane with the tubular basement membrane, which is so thin, I thought it is membranous, because majority of the capillary loops were showing this kind of a thickening. I thought it is membranous, and in advanced membranous also you can find some duplication. Okay, I'll show you. Yeah, here you can see this clearing of the capillary wall here. So there is some duplication of the glomerular capillary wall. So you have to remember, even in advanced membranous, you can find these kind of duplication. You can see this duplication here also. I'll see. Yeah, just see here. You can see here duplication, clearing of the thing. So I thought my diagnosis was membranous, and on morphology, I even told my nephrologist that we are dealing with membranous, because this patient had some 1.5 or 2 gram kind of proteinuria also, and but there is a history of breast carcinoma post chemotherapy. Okay, so again another image which shows that there is a thickening of the membrane and there is duplication of the membrane also. So this also I won't say that this is classical like Amphigen pattern, but you have to remember it shows some features of Amphigen because there is duplication of the glomerular wall. Okay, so you have to remember all these now newer drugs which are coming, chemotherapy, therapeutic agents, immune checkpoint inhibitors. Now we are seeing biopsies uh, of kidney biopsies which are showing thrombotic microangiopathy. Okay, so thrombotic microangiopathy can look just like membranous. And if you remember, this lecture is mainly on native kidney biopsies, Amphigen pattern. But when we talk about Amphigen pattern in transplant biopsies, chronic thrombotic microangiopathy and chronic AMR, antibody mediated rejection, they look very similar on morphology. The only difference is C4D staining in chronic AMR and glomerulitis or PTC capitis or TM or sorry TMA you will be seeing in both the things. So the thing is the morphology of chronic TMA is similar to membranous, is similar to chronic AMR in antibody mediated rejection and very similar to membranous, advanced membranous. How you will be able to differentiate in membranous, there will be no immunofluorescence. In membranous there will be immunofluorescence which will be positive. There will be IgG 3 plus granular. There will be C3 which could be 1 plus or which could be trace, or in a primary membranous kappa lambda will show staining, equal staining, granularity. But in chronic thrombotic microangiopathy, since uh, it is not a immune complex kind of a thing, so immunoglobulins will be negative except IgM. You have to remember one important point. Whenever there is a duplication of the glomerular capillary wall, even in diabetes also, whenever there is segmental steatosis or hyalinosis, there will be non-specific IgM trapping. So you are going to see non-specific IgM trapping in cases of chronic thrombotic microangiopathy, but IgG and other things will be negative. So uh, when I looked at the immunofluorescence, I was sure that yes, this is not membranous, this is something else. So I looked at this case more carefully and realized that this is a chronic thrombotic microangiopathy, possibly related to the chemotherapeutic agent. So this was my last slide, and I thought I'll try to cover up this Amphigen pattern, and you should remember that Amphigen pattern can occur in any disease, starting from diabetes, amyloid, light chain deposition disease, to your C3 glomerulopathy, immune complex mediated disease. So don't, whenever you see Amphigen pattern, your thought process should be like, it could be a immune complex Amphigen, which could be infection or autoimmune disease associated, or it could be Amphigen with dysproteinemia. It could be C3 glomerulopathy, which includes C3GN and nestic deposit disease. It could be Amphigen due to some hypertension or diabetes. Even a hypertensive nephrosclerosis can show, if you remember, if you know, hypertensive nephrosclerosis can lead to chronic TMA. And chronic TMA will have very similar picture what the slide which I'm showing you now. Okay, so diabetic nephropathy, amyloid, light chain deposition disease. So all these differentials should come to your mind whenever you see a Amphigen pattern. So if there are any questions you have for me, I'll be happy to answer them. So in the chat box, I'll see if, okay, so the question is, I'll start from the first one. Unmasked light chains, okay, class C diabetic nephropathy, LCDD nodules are also more cellular. Yes, so LCDD nodules are more cellular when they are early, when we are dealing with early stage of LCDD. In late stages of LCDD, they will not be cellular. Weak PS positive, absolutely correct. So I'll go through that. Lambda restricted TPM thickening is diabetic fibrillosis. So how to differentiate TG from, so diabetic fibrillosis, when we say, this is a thing which you get to see in electron microscopy, and I think this must be related to when I was showing you those substructure within these deposits. So that was actually Amphigen with dysproteinemia rather than diabetic fibrillosis. And how to differentiate TG from chronic TMA, this we are dealing with a native kidney biopsy, but I'll tell you how to differentiate, because morphologically transplant glomerulopathy, I'll tell you one important thing. When we say transplant glomerulopathy, so transplant glomerulopathy by definition means there is thickening, non-uniform thickening and duplication of the glomerular capillary wall, full stop. Transplant glomerulopathy doesn't mean it is transplant glomerulopathy is not synonymous with chronic antibody-mediated rejection. First, the foremost important point. What happens is, majority of the time, whenever we say TG, we think it is chronic AMR. That is not correct. Because TG is a morphological term. TG means there is a thickening of the glomerular capillary wall and there is a duplication of the glomerular capillary wall. Okay. Now, which all diseases can produce duplication and thickening of the glomerular capillary wall? I have shown you, since we are dealing with Amphigen today, Amphigen can show duplication. Chronic thrombotic microangiopathy can show duplication. And this I'm talking about only native disease. Now, if you see in the transplant setting, these two diseases will be the same. Amphigen will be there. There could be chronic thrombotic microangiopathy. There will be chronic antibody-mediated rejection. So when you say how to differentiate TG from chronic TMA, your question should be how to differentiate chronic AMR from chronic TMA. Okay? Because in TG, there all these four differences will be there. So how to differentiate? If there is Amphigen and you have to differentiate it from chronic AMR or chronic thrombotic microangiopathy, Amphigen, immune complex mediated Amphigen will show immune complexes. Okay. But TG and chronic thrombotic microangiopathy, or sorry, chronic AMR and chronic thrombotic microangiopathy will not show any immune complex deposit except for non-specific IgM trapping. Okay. Now we'll talk about how to differentiate chronic antibody-mediated rejection from chronic TMA. For both these things morphologically look very similar. If you find glomerulitis, if you find PTC capillaritis, if you find C4D positivity, it goes more in favor of chronic thrombotic microangiopathy. Many times, 40% of cases of chronic antibody-mediated rejection will be negative for C4D. So those are very problematic cases, because in those cases, then we have to go for electron microscopy. I'm not saying DSA. DSA will be the final step, but go for electron microscopy. In electron microscopy, if you find extensive multilamelation of the glomerular basement membrane, okay, then it is more in favor of transplant glomerulopathy. If you find significant multi-layering of the peritubular capillary basement membrane, so that means normally peritubular capillary basement membrane can have 2 to 3 layers. If you find 3 PTCs with 5 to 7 layers, or even a single PTC with more than 7 layers of multi-layering, that is classical of a chronic antibody-mediated rejection. So that's how you can differentiate chronic AMR from chronic thrombotic angiopathy. How membrane duplication occurs in Amphigen. So that I've told you, there is a repeated endothelial injury which goes on, and then a new basement membrane is formed. So there is a remodeling of the glomerular basement membrane because of endothelial injury. There will be some reparative process, and that reparative process produces a new membrane. So there is extensive remodeling of the glomerular basement membrane, and that is why you see duplication under light microscope. Why linear IgG accentuation in diabetes when there is no immune deposit? Yes. So linear accentuation in diabetes occurs because a diabetic glomeruli or a diabetic patient, the tubular basement membrane as well as the glomerular capillary wall, there is non-specific adsorption of immunoglobulins there. And because of this kind of a non-specific adsorption of immunoglobulins, you get to see this kind of a linear accentuation. So good thing is you have said linear accentuation, not linear staining, because always remember linear staining should not be used for diabetes. Just say linear accentuation. Okay. If in a monoclonal immunoglobulin deposition disease, serum protein electrophoresis and free light chain assays show IgM kappa type, will same be shown in IF also, like IgM deposition? Absolutely. If you don't find this, that means there is some problem. That means the interpretation is not done correctly, because if there is IgM kappa, which is, and I must tell you, when you find IgM kappa type, majority of the times cryoglobulinemia will produce dominantly IgM kappa type of immunoglobulins, and well-destroyed macroglobulinemia. These are the settings where you find mostly IgM kappa type of deposits. Is there a possible explanation for lambda predominance in IgA? Yes, there is a possible explanation. What happens is there are multiple IgA subunits. So somehow the IgA subunit which get deposited in primary IgA nephropathy, that has more adhesive properties towards lambda, and that is why lambda is more significantly deposited in the primary IgA nephropathy. So many times in primary IgA nephropathy, when I look at morphology and I see lambda dominance, I am sure that we are dealing with a primary IgA nephropathy. Now, in an elderly patient, if you find kappa dominance and no lambda, you should suspect some kind of a monoclonal pathology also. Okay. Normally, IgA is a disease of young and middle-aged people. So it is not that you can't see in an elderly population, but yes, in an elderly population, if you find IgA and kappa dominant, think of that. In a young patient, if you find IgA kappa, think of secondary IgA. HSP nephritis will show more kappa staining than lambda. Primary IgA will show more lambda staining. So I have answered majority of your queries in the chat box. So if there are any further queries, please you can ask or we close this session. Okay. If is there a possibility? Okay. If in a monoclonal immunoglobulin deposition disease, serum protein electrophoresis FLC show IgM kappa, will same be shown in IF also like IgM deposition kappa? Can't we have a, yes, we can have a biclonal disease, bimodal peaks, but that is a very unusual thing. But I must tell you, if you say it is a biclonal disease kind of a thing, then you should have, along with IgM kappa, you should have one more band, IgA or IgG kappa band. Then only you can label it as. So serum electrophoresis will show both these things. And I have never come across a case where there is a biclonal peak and I'm seeing only deposition of one thing. But yes, you are correct that there are few cases, occasional rare cases where you can see a biclonal disease, but that is very unusual. His first case can't be IRGN, infection related GN, and different and DD, any DD. Okay, so the thing is, I must say that whenever you find C3 deposit, see, understand there were some papers of atypical or atypical infectious glomerular nephritis, because see, understand the concept of C3 glomerular nephritis or C3 glomerulopathy came in because there were some cases of infection associated GN, which were initially labeled as post-infectious or infection-related GN. They have seen that when they followed up these patients, the proteinuria increased and the hypercomplementemia was persistent. So then they studied these cases further extensively. Then they realized that it is actually not post-infectious or infection-related GN, but actually a C3 glomerulopathy. So I must tell you one important thing. I remember looking at one case post-transplant. This was like 3 months post-transplant, AV1 compatible, where the morphology was diffuse proliferative. So diffuse proliferative means that there will be no thickening or duplication of the glomerular capillary wall. There will be only endocapillary proliferation, which will be rich in neutrophils. Okay. Now that is classical morphology, and there were only C3 deposits. So when you find only C3, remember that infection-related GN will show some IgG majority of the time, but sometimes IgG will not be there, only C3 will be there. And when isolated C3 deposits are there, there is a problem shedding post-infectious or infection-related GN from C3 glomerulopathy. So I'll come to the same case. So 3 months post-transplant, proteinuria was 2 grams, and biopsy showed diffuse proliferative glomerular nephritis rich in neutrophils, only C3 deposits, and electron microscopy showed subepithelial humps, numerous. I labeled it as a post-infectious glomerular nephritis. After 2 months, the proteinuria increased from 1.5 or 2 grams to 6 grams. Repeat biopsy was. Repeat biopsy showed lobular accentuation, thickening and duplication of the glomerular capillary wall, all the morphological findings of Amphigen. Okay. And again, C3 deposit. There was persistent hypercomplementemia. So what I want to tell you is, early the biopsy you do, you may find changes which are more in favor of a infection related GN. But as the disease progresses, you are going to see a classical Amphigen pattern. Okay, so even a C3 glomerulopathy in early stages can show morphology very similar to post-infectious glomerular nephritis. It is the clinical picture, which it is a clinical follow-up which will tell you whether this patient is behaving like a C3 GN or whether this patient is behaving like an infection-related GN or a C3 glomerulopathy. But the case which I've showed you, that show duplication also. So when you find local accentuation, it is unusual for infection-related GN to show local accentuation. Infection-related GN will not show thickening and duplication of the global capillary wall. As I've told you, the reason for that is persistent antigenemia. So in infection-related GN, if it is mostly, it is not a persistent antigenemia. That is why you are not going to see duplication of the global capillary wall. Yeah. The resolving PIGN with C3 creates confusion with C3GN. Okay. So I'll tell you, resolving PIGN and C3GN. Resolving PIGN will show mesangial hypercellularity. It will not show endocapillary proliferation. Okay. And resolving PIGN, the deposits are mostly in the mesangium. Okay. Because the pathology lies in the mesangium. Morphologically, there will be only mesangial hypercellularity. Now, C3GN, if it shows only mesangial hypercellularity, okay, then there could be morphological problems in differentiating C3GN from PIGN, resolving PIGN. But if you do ultrastructure examination, okay, ultrastructure examination, if you find subendothelial deposits, okay, then it goes more in favor of a C3GN rather than a resolving PIGN. Okay, because the resolving PIGN will show only mesangial deposits. Okay, there will be no subepithelial hump and all that. But in C3GN, the deposits can be seen in the mesangium as well as in the subendothelial space. And the other thing, what I've showed you is the deposits of C3GN are very pale and waxy deposit. They are not that electron dense. So these two findings can help you in differentiating when it shows only mesangial-proliferative pattern of C3GN is there from resolving PIGN. Yeah. Any more? How common is starry sky pattern in IgN? So a starry sky pattern you see mostly in acute infection-related GN or post-infectious acute infection-related glomerulonephritis, and it is not that uncommon, I must say that, because whenever you see dot-like pattern, okay, that is very classical, like a starry sky pattern which you see in IgN. And the starry sky pattern is because there are numerous subepithelial humps which you will be able to appreciate on ultrastructure examination, because those are like lumpy and bumpy deposits. And how often one find it difficult to differentiate IgN from C3GN? So see, the thing is, as I've told you, it is difficult, but your clinical follow-up, and if you do everything, that means light microscopy, immunofluorescence, as well as electron microscopy. So if you do, it is possible that you will come to a conclusive diagnosis. So whenever I am in a situation that I need to differentiate infection-related GN from C3GN or ultrastructure examination, majority of the times, like when I say 80 to 85% times, we are able to favor one over other, okay, based on whatever findings we are seeing. If I find a lobular accentuation, if I find uh, duplication of the capillary wall, if I find subendothelial deposits, which are pale waxy kind of deposits, it all these findings favor a C3GN over infection-related GN. Yeah. And the other thing is sometimes in infection-related GN, you can also see, because in infection-related GN, there is a classical complement pathway which gets activated and not an alternate complement pathway. So in infection-related GN, sometimes you also see C1q deposition, which you'll not see in C3 glomerulopathy. Any further questions? So if there are no further questions, then thank you. Thanks a lot. And if you have any further queries, you can always address it to me. Okay, you can share it with Mr. Puneet, and I'll be happy to answer. Okay, thank you and good night. Bye.
Thank you so much, sir.
Okay.
It's always a pleasure to have you.
Okay. Thank you.